Well, that's partly what got me interested in this field. I read
Mm,
Linus Pauling's book in 1972, Vitamin C and the Common Cold. And he cited all of the available evidence at the time that vitamin C reduced the duration. And he also went into a long discussion of how the medical community can't relate to this. So that's
mhm,
partly Roger Williams and Linus Pauling's books were what got me interested. But
mhm.
over the years, vitamin C has a lot of uses, and often it's supportive for general health. I mean, it prevents bruising, it helps prevent heart disease to some extent. There's some evidence that helps prevent cancer, many different things that you can use it for. I typically recommend a minimum of 200 milligrams a day.
Welcome to the show, Dr. Alan Gaby. It's a pleasure to have you on Smarter Not Harder podcast.
Thank you. Nice to be on.
So, Alan, I love to ask this question, and it's curiosity in me also is that I love to know why and how people land where they do. And so for you, nutritional medicine, what was the journey there? What drew you to that?
Well, I'd like to think that I haven't quite landed yet, that I'm still flying, but I understand the question. So, I came from a medical family. My dad was a surgeon, and
Hmm.
he pushed me to go into the medical field as a youngster. And I looked at what was being done, and I didn't really relate to it. So I went to college. I went to Yale University, which is a good college, but I didn't try very hard, and I didn't do very well. And I got rejected from medical school, which was kind of fine because I didn't want to go. Uh,
Yeah.
but then the following year, I read a book by a biochemist named Roger Williams. The book was called
Hmm.
Nutrition Against Disease. Roger Williams discovered one of the B vitamins, pantothenic acid. He also named folic acid because it comes from foliage, so he called it folic acid. And this book was amazing to me. It was an eye-opening thing showing that nutritional supplements and dietary changes can be useful for preventing and treating a wide range of illnesses. And at the same time, it was being totally ignored by the medical profession. So I was 23 years old. This was in 1973.
Mm.
And I had an epiphany. Uh, Einstein would have said that epiphanies are God's way of remaining anonymous. And I had a moment of clarity. It was in an instant. I was kind of lost in my life, not knowing what to do. And all of a sudden, I was given this idea that I was going to learn everything I could about nutritional therapy and teach the world. So
Mm.
I went from a aimless life to a purpose-driven life, and it's been going that way for 52 years now. So what I did is I went to graduate school in biochemistry, for
Mhm.
one, to give myself a basis in nutritional medicine, and for two, to demonstrate to the medical schools that I could be an acceptable student for them. So I got all A's in grad school and did well and got into medical school, learned what I was supposed to learn there. And on the side, I just did this other track. I read everything I could find on the nutritional medicine. After graduation, I was very fortunate to be able to go into the practice of a noted pioneer in this field, Dr. Jonathan Wright. And so I practiced with him for a couple of years. And during that time and afterwards, I spent half of my time seeing patients and half of my time in the medical library. This was around 1980, going
Mm.
through the table of contents of all of the medical journals in the library that had any relevance. This was a 2-year time frame, just going through the table of contents. And I continued after that. We went all the way back to 1900 and then continued looking at all the new journals as they came in, which I've continued up to this day. So it takes a
Mm.
lot of time. We didn't have the internet back then.
No, it
Um,
was very different, wasn't
but
it?
now we do. And so I can just do literature searches on the National Library of Congress. It's much faster. But so during that time, I compiled all of the relevant articles all the way back to 1900 and now currently up to
Mm.
2025
Mm.
and summarized them, categorized them, analyzed them. And when the Microsoft Office came out, I was able to use that. It allowed me to do my work 20 times faster than I ever would have been able to. So I had about 30,000 articles categorized, keyworded, and was able to organize them into conceptual frameworks, individual nutrients, how you use them, what they interact with, what the adverse effects are, things like that. And then specific diseases and how you can treat them nutritionally. So it was a 30-year project, half of my time seeing patients, half of my time working on this. And finally, I was able to come up with this large textbook, which when you look at other large textbooks, they have 50 or 100 contributors. I did this all by myself. And I remember I used to go to the holistic medical meetings and I'd tell people I'm working on this book in the 1980s. And then in the 1990s, so what you doing? I said, oh, I'm working on this book. And then in the 2000s, you still working on that stupid book? Anyway, it finally came out in late 2010 and it's been updated twice now. And that's been my life's work. And I'm very happy with it because what I think it does is it helps doctors practice nutrition safely and effectively. And it looks at what's really effective and what's not. As you know, there's a lot of hype in this field. People are trying to make a lot of money. So if I don't think something works, then I say so. And if I think something does work, I say so. And if I read an article and it appears that it might be fraudulent, which I'm finding more and more studies from Iran and sometimes from Egypt, Japan, Italy, surprisingly, you read these articles and they're impossible. They wrote these things about research they never even did. So that's becoming more and more of a problem. And in the third edition, I actually got much more tuned into that and took out some stuff that I'd put in the first and second edition. But all in all, the field has not changed that much. I mean, what I wrote in 2010 is not that much different from the updated version.
Yeah. That was my next question to you, was what you have noticed, across the over 50 years of work, and what an incredible compilation, and how lucky we are to have access to something like this that you have put blood, sweat and tears into. Because as you said, it's just so hard to be doing that research back when you started, because it was a different level of dedication. Now we have even AI, and sometimes I don't think it's always the best, because again, you get searches and some of those, the articles, like you said, who are fakes or weren't even done in terms of the research are showing on there. So how are we even able to discern what is real? And it's only from reading in depth about these. So I guess in the last sort of 15 years, you say it's not changed too much, which is good. We obviously need more research though. That's sort of pointing out. But what have you noticed since starting over 50 years ago in the nutritional field? Is it becoming more accepted? Are you still feeling that doctors and practitioners are still very resistant against this comparatively to how you would wish it would be?
Well, let's put it this way. When I started in 1973, people thought I was a complete lunatic. Nowadays, there is a significant percentage of the medical community in the United States that still thinks that. But nutritional medicine, and as you know, naturopathic medicine embraces this greatly. Naturopathic education started in the United States around 1980, and there are several thousand practitioners here. There are a lot of chiropractors that are interested, some dietitians, depending on their philosophy. And then there are other groups, nutritional therapists and medical doctors. There's a minority that would call themselves, say, integrative medicine practitioners, which includes nutrition and many other things. But I would guess it's still less than 5% of medical doctors in the United States, but it is growing. And I get surprised sometimes. I got invited, I'm in the state of New Hampshire, and I was just invited a few weeks ago to speak to the New Hampshire Academy of Family Physicians about nutritional medicine. It's like, wow, I hope they don't throw eggs at me. Medical doctors are very dedicated. And when I gave seminars with Dr. Wright back in the 80s and 90s and 2000s, we'd get practitioners from all over the country and we'd say, why did you come? And they said, well, I just get tired of seeing the same patients every month, same problems. I give them a new drug. It either doesn't work or it causes side effects. And I want to look at something new. And then they start doing some of this nutritional therapy and I get emails from them and said, well, I'm getting results that I was not able to get before. And it's not a cure-all, but there's definitely, for example, physicians who do not look at hidden food allergy as a cause of illness, in my opinion, cannot possibly be getting optimal results. I saw so many patients over the years that had seen multiple specialists. And in many of those situations, it was just a hidden food allergy, dairy products or wheat or eggs or corn or things like that. And you get them off of 3 different diseases for which they're seeing specialists. Now,
Yeah.
again, it doesn't work all the time, but it's so safe and so inexpensive that, in my view, if the medical community would embrace this, we would reduce the cost of healthcare by 30 or 40% within a few weeks. Well,
I
maybe
couldn't
not
agree
that
more.
fast, but you know what I'm
Yeah.
saying.
Yeah, absolutely. I couldn't agree more. Um, at Home Hope, we encourage and we teach about the IgG testing, and we encourage and teach about doing organic acids testing, doing serum appropriately, doing gut microbiome testing appropriately, because it is so important. And this is why I was very excited to speak to you, because you have been in the industry much longer than I have. And yeah, I have so many frustrations, as you would have heard many, many times, with talking with general practitioners or even specialist surgeons, and cardiovascular diseases, going in for huge surgeries, coming out. The clients will be asking, what do I need to eat? What do I need to be doing? Or nothing. Nutrition doesn't do anything. Oh,
They're saying that about heart disease? That's pathetic. I mean, if the one area where conventional medicine should know it has an effect should be
yeah.
heart disease.
You,
I mean,
you,
if they
you
want
would
to say
think.
it has nothing to do with arthritis or migraines, which is
Yeah.
wrong, then
Yeah.
I can at least understand that, but not heart disease,
Yeah.
not diabetes.
It's crazy. They don't get any advice in terms of how to change their lifestyle diet after having these huge life-changing surgeries. And that's what blows me away daily. But from my perspective, when you look at the biochemistry, there's nothing without nutrition. They are the
Absolutely.
cofactors which run our cellular environment.
Right.
It's essential, and our microbiome. So that's, for me, it's a complete no-brainer. And I just look at people when they give me comments as such, and think, where have you been? Did you even do your biochemistry?
Well, you didn't go to conventional medical school. They kind of drum a certain viewpoint into you, and they
Right.
don't teach any of this. My son is now in his 2nd year of medical school, and we talk about various diseases. And I say, for example, do they say that wheat allergy is a common cause of migraine? Oh, no, they don't ever say anything like that.
Yeah.
So it is slow, but at least it's going in the right direction.
Yeah. Yeah. I agree. I think it is going in the right direction. All right. So let's dive in. It's hard because I want to start everywhere at once. So obviously your book looks at so many different factors associated with nutritional medicine, and you list out all the different vitamins, minerals, and you're looking at all these in an individual sense. And obviously we have to look at them as entourage effect in the body, that we're looking at them. They all work and they all interact in some way with one another. So what in your mind is sort of the first pick for educating practitioners, doctors in nutritional medicine? What are the key ones that you would pull out that may have not had enough ground in the literature or ground in education?
Are you talking about the key nutrients or dietary factors?
Let's dive in, narrow first, and then we'll come out
Okay.
a little bit broader later on. But let's go into individual vitamins, nutrients, minerals, so from that perspective.
Okay.
Mm.
Well, I would venture to suggest that if Western society increased their magnesium intake by about 50 to 70%, we would have a dramatic reduction in a wide range of health conditions. The recommended dietary allowance for magnesium is around 400 milligrams per day, and 70% approximately of people do not achieve that, and many of them don't even get 2/3 of it. In addition, there's some evidence that the RDA is too low because it does not account for various other factors, and the way they measured it is open to criticism. In my clinical practice and based on the literature, I've seen so many people with a wide range of conditions: anxiety, depression, fatigue, migraine headaches, muscle weakness, muscle spasms, restless leg syndrome. The list is very, very long. And of course, cardiovascular disease, diabetes has a component as well. So, for example, somebody comes in, they drink a little more alcohol than they should, but not terrible, and they're suffering from anxiety. Try 400 milligrams of magnesium. Bam, 24, 48 hours later, they say, wow, I'm so much better. So, okay, maybe you can stop drinking too now, but so a wide range of problems are benefited from magnesium. And so I often recommend a supplement. As far as which type, there's
Yes.
conflicting literature on that. Magnesium oxide has a bad reputation because there's one study that says it's poorly absorbed. And also, it's very inexpensive, and you can get a lot more elemental magnesium per capsule. So if it was effective, I would actually prefer that for those reasons. And I'm aware of at least 6 studies with 6 different health conditions where they gave magnesium oxide versus placebo, and the magnesium was effective. Hypertension, premenstrual syndrome, anxiety, things like that. And the urinary magnesium went up and the symptoms got better. So the fact that the urinary magnesium went up means it got absorbed. So maybe it's not as effective. It's certainly, more likely to cause GI side effects than magnesium glycinate. But magnesium glycinate is more expensive and you have to take more pills to get the same amount of elemental magnesium. So most of the time, unless I think somebody's got an absorption problem, I'll go with the cheap kind. And if somebody wants to use mag glycinate or other forms, then that's perfectly fine. With respect to specific conditions, sometimes I'll use a specific form of magnesium. For example, there's a whole body of research on the use of the potassium and magnesium salts of aspartic acid. It's called potassium magnesium aspartate. And there are 4 or 5 randomized controlled trials from the 1960s. And parenthetically, you asked me about what's new and whether things get outdated. These studies have never been followed up. There were 5 or 6 studies in the 60s, and they all showed the same thing, that potassium magnesium aspartate is an effective treatment for unexplained fatigue. About 85% of people who take it improve, compared to only 15 to 25% of people who take a placebo. So if somebody is experiencing fatigue of unknown cause or muscle spasms, it also seems to help more for that. I'll go with potassium magnesium aspartate. And otherwise, like I said, the oxide is perfectly fine. So that would be, magnesium would be my first. Other ones that are very important: folic acid, vitamin C, B vitamins, but specific conditions, you look more at specific vitamins.
Yeah, absolutely. Yeah, I think it's an important point on magnesium. And also another important point that you made is meeting people where they're at. And so sometimes you have to start with something. And that's what I find in my clinical practice, is that you have to be really good at knowing what is going to work on the person at that time. Because if you start really big and they're not ready for it, then you're never going to help them. And so starting at a place where they can afford it, or they can take enough of a specific vitamin or mineral that's going to get them through, and that bridge to that next point is, I think, essential, for making movement in this field.
Well, I agree with your viewpoint. And one of the things I've seen over the years is patients come in with a big shopping bag of 30 or 40 bottles. And, I read that this is good, so now I'm taking this. And is there any way you can reduce my number of pills? Because all I'm doing is swallowing pills and spending all my money. So, it is important to try to prioritize. I generally start with a multivitamin, multimineral, extra magnesium and calcium, because a lot of the multis don't have enough of that, particularly the one-a-days.
Yeah.
And then from there, based on what their problems are and what their risk factors are, I'll try to build a program. But I agree, you don't want to load too many pills on. And though diet is crucial, diet is as important, if not more important, than supplements. But there are many people who are not willing or able to make the change. So like you said, you meet them where they're at. This fellow I saw recently had Crohn's disease, and he told me that when he went to Italy, it went away. And I'm thinking, what could that be? Could it be mold? He said, no, it wasn't mold. It doesn't have a moldy house. One thing I've been aware of over the years is the wheat that they grow in Europe is quite different from the wheat that they grow in the United States. And I've seen many people who told me that they do not tolerate United States wheat, but when they go to Europe or Israel or some other countries, they tolerate it fine. So based on that one clue, I said, well, maybe you've got a wheat sensitivity, because we know from old literature that hidden food allergy, particularly wheat, dairy products, corn, and eggs, can trigger ulcerative colitis and Crohn's disease. And I knew this kid was not willing to do a big elimination diet, no wheat, dairy products, corn, eggs, citrus, coffee, tea, alcohol, sugar. He wasn't going to do it. So I made an educated guess, say, well, let's see if you can just get off the wheat, which he did very diligently. And he's much, much better now. So, like you said, you have to meet them where they are and what they're able to do.
Yeah, absolutely. And I too notice this, not only the bags of supplements, but I have clients also who can eat wheat everywhere else, well, except for Australia and the US. Definitely improves and they feel so good. And I think it helps with maybe sunshine and walking and being more relaxed as well. I think it increases the healing potential there. But yeah, it's a very important point because we have that close, obviously, the integration with the gut. And if we are irritating that with any food allergies, and that's where the testing, the intolerance testing can come in, because it's so easy then to know, well, this is the things that are irritating now. And that's what we can remove. Yeah. So I want to move into food in a minute, but for particularly vitamin C and B vitamins, and you mentioned folate, and that's an interesting one. And I've read some of your blogs on this as well. So we obviously hear a lot about it. There is a lot about methylated vitamins out there. There is a lot about the MTHFR genes. So your perspective on that, and then also into vitamin C and B, Bs particularly, and obviously the methylated versions. But my segue is because with foods nutrition, we don't have the value of the nutritional quantity in them at the moment. And that's what I think is declining as I've read. So, what do we do about that? And so that's my segue into that. So maybe we start with the vitamin C and Bs.
Okay. So regarding folic acid or folate, folic acid does not occur in any large amount in the body. And it has to be, when you take it as a supplement, the reason they use it is because it's stable and it's inexpensive. So they put it in most of the multis, but it has to be activated to methylfolate and some other related compounds. So a lot of manufacturers in the past 10 years have decided to use methylfolate instead of folic acid. And some doctors won't use any multi that has folic acid in it anymore. So I looked at that from a couple of perspectives. Number one is virtually 100% of the research on the use of folates as a preventive for various problems and as a therapy has used synthetic folic acid. So since we have not used 5-MTHF as a therapy, we can't be 100% sure that it would work as well. I mean, theoretically, it would work better, but until you do the research, you don't know for sure. One of the problems is it's less stable. So when you have it in a multi, there's a potential for degradation when you mix it with redox agents like vitamin C or copper or thiamine. That has been clearly demonstrated with vitamin B12. It degrades in multivitamins because of those reactions. Whether methylfolate does that too, we don't know, but it's a possibility. The other thing is we don't know how the transport mechanisms work. Does methylfolate get into cells as efficiently as folic acid does? As an analogy, people with Parkinson's disease, they have a dopamine deficiency in their brain, but if you give them dopamine as a therapy, it won't work because it will not cross the blood-brain barrier. So you give them levodopa or L-Dopa. L-Dopa crosses the blood-brain barrier where it gets converted to dopamine. So by analogy, I don't know whether that applies to methylfolate, but there's a theoretical possibility that it wouldn't work as well. So we need to do the research. The research that's been done has been sparse. But one thing that was surprising was that when you try to lower homocysteine levels, folic acid actually works slightly better than methylfolate. And when you look at the specific group, the MTHFR 677C to T allele that there's a couple of them, but that's probably the one you're referring to. That's the one where supposedly you cannot convert folic acid to its active substances, and therefore you have to take the active form. When you look at that, folic acid actually worked even better for homocysteine lowering than it did with people without that TT gene. So that research does not support the clinical use of methylfolate. The other place that they've looked at is as an adjunctive therapy for depression. They've given people fluoxetine, which is Prozac, and they tacked on either folic acid or methylfolate. Methylfolate is actually a prescription drug in the United States. I think it comes in 7.5 milligrams. And what they found is that as little as 0.5 milligram of synthetic folic acid can support or improve the benefit of fluoxetine for depression, whereas you have to get 15 milligrams of the methylfolate, and 7.5 milligrams was not effective. So for those reasons, I've been skeptical about routinely using methylfolate. Now, are there situations where it's more effective? Probably. I don't necessarily know what they are, but I'm sticking with the old form until I see better evidence.
It's a really interesting point you make. And, the fads, I don't call them fads, but I think it's experimentation for the purpose of getting, further in nutrition and medicine. But you don't always know until there is long range studies. And this is the thing, or more, together. And so you are trying to assume and test and just throw things at patients to be able to guess this. And so you don't always know, but there is a big body of practitioners and educators speaking on methylfolate, isn't it?
And I can't say they're wrong. What I can say is it's premature to be convinced 100% that they're right.
Yeah, absolutely.
There's a medical legal issue, at least here in the United States. The United States Preventive Health Service recommends folic acid for all women of childbearing age to prevent neural tube defects. It does not say anything about methylfolate. And so if you give methylfolate and a baby gets a neural tube defect and you get sued, and then the lawyer says, well, where does it say you should be giving methylfolate? Now, did they do something wrong medically? Probably not. But from a legal standpoint, that's a concern too.
No, absolutely. Yeah, I want to get into some of the interactions and everything in a minute, but I think I'll come to that after we talk about the nutrition part. But before we move to that, vitamin C. Now, I'm seeing a relatively huge deficiency state in many people, and even from the metabolite testing that we do as well. I notice this quite often. And I think it is because of the processing component of our food and highly packaged foods that we eat, and also shelf stable and picked early and all these other things that we talk about. So in terms of the body of evidence around vitamin C, what have you noticed over the years and what's changed?
Well, that's partly what got me interested in this field. I read Linus Pauling's book in 1972, Vitamin C and the Common Cold. And he cited all of the available evidence at the time that vitamin C reduced the duration. And he also went into a long discussion of how the medical community can't relate to this. So that's partly Roger Williams and Linus Pauling's books were what got me interested. But over the years, vitamin C has a lot of uses, and often it's supportive for general health. I mean, it prevents bruising. It probably helps prevent heart disease to some extent. There's some evidence that helps prevent cancer, many different things that you can use it for. So I typically recommend a minimum of 200 milligrams a day. That's probably sufficient for the average healthy person. That's about twice the recommended dietary allowance. Smokers, as you know, need more. For people with chronic illnesses, that's another story. A lot of times they might need much more, and you just take it one case at a time. One of the things that Pauling cited, he cited the work of someone named Irwin Stone, who was not a physician, but he was very smart. And he pointed out that humans are among the few species that do not manufacture their own vitamin C. And among those that do manufacture their own vitamin C, they make dramatically more than humans can get in their diet. And when they are stressed biochemically, or cold stress, or they give them an infection, or they give them a trauma, there is one thing that happens. The liver starts cranking out more vitamin C up to the point of approximately 19 grams per 70 kilograms of body weight. And so that was the basis of a lot of the orthomolecular medicine theories of why people might benefit from very large amounts of vitamin C. And in some situations, I use that. I used to give people that got recurrent urinary tract infections who didn't tolerate antibiotics, we would hook them up to 25 grams of vitamin C and drip it in through a vein over a period of an hour. and that would knock out the problem. Some people with infectious mononucleosis, high dose intravenous vitamin C would get them well in a matter of days rather than weeks or months. And that was based on the work of a man named Frederick Klenner from the 1930s and 1940s. And I cited this all in my book, and there has not been a whole lot of follow-up. There's some doctors who are doing work now with cancer and vitamin C, and they publish occasionally. But again, you look back at some of this work, and I wish it was being followed up. And maybe if we keep banging pots and pans and screaming and yelling, people will start doing some of the work. But I think vitamin C, both orally and intravenously, has great potential.
Yeah, I absolutely agree with you. I speak to many doctors and patients as well who are and have been on vitamin C therapy for cancer and various other immune issues, and incredible benefits that I've seen as well. Yeah. So it brings me to my next question before we sort of come away from some of the micronutrients, minerals. How is there a set protocol when you're seeing clients, patients? Is there a set protocol testing that you like to do in terms of how you determine what patients are missing and how, I know it's a big question. I know that.
Yes.
But maybe some guidance on what you're looking for when you're seeing patients.
Okay, well, I'm different than many of the practitioners that do the same kind of therapies. I give a good history, good physical exam, and standard laboratory tests, chem profile, complete blood count, serum iron, things like thyroid function. But I almost never have used any of the nutritional testing. One reason is that I think a lot of people who benefit from nutritional therapy are not deficient. I think what we're doing sometimes is we're cranking up enzymes by giving supra-physiological doses, above the amount that you would normally get in a diet. Sometimes we're inhibiting enzymes, sometimes we're activating them, sometimes we're having pharmacological effects. For example, with vitamin C in the urine can partly sterilize organisms, so it can reduce the risk of UTIs. Magnesium in the urine increases the solubility of oxalate. So there are studies over the years that showed that if you give 300 to 500 milligrams of magnesium per day to people that had recurrent calcium oxalate stones, kidney stones, then the recurrence rate drops by 90%. And the presumed mechanism is that it increases the urinary solubility of oxalate, which we know chemically magnesium does. So, they always disparagingly say, all you're giving people is expensive urine. But in this case, that expensive urine is worth it. So
it's doing its job.
Back to your question. So I have a familiarity with the literature, what's been used for what conditions. And based on that, and based on the patient's history and physical exam and standard laboratory tests, I basically wing it, educated guessing, if you will. And that seems to work pretty well. Now, am I missing some things because I'm not doing the testing? Maybe, but my success rate was pretty good. And the failures, I just chalked them up to failures. That I would say at least 80% of the people that I worked with responded well based on what we'll call empirical therapy.
And that there is a huge amount of intuitive analysis that goes on, isn't it? And I think we don't talk about it enough because it is hard to quantify. And any practitioner or doctor that's been working with patients for longer than a couple of years, you will read someone as soon as you walk in. You'll see signs without, you actually registering it in your intellect. And so we work with so many different tools and techniques, don't we? And sometimes, patients, that many work with, including myself, can't afford the testing. And so it's not cheap in some regards. So we have to work with what we've got. And so then you're reading the patient and you're knowing what is working for them and how their body is responding and teaching them what to be looking for. And so it is that nutritional counseling that goes a long way, I feel.
Absolutely. And, if one starts to pat themselves on the back too much for being smart and coming up with intuitive therapies or based on your knowledge, I always remind myself of this one case. This woman came in. I don't remember what her problem was, and I don't remember what I gave her. but I was patting myself on the back of how smart I was. She comes back 4 weeks later. I said, "How you doing?" She says, "I am so much better." And I'm thinking, "Oh, I'm so smart." And then I says, "Well, which portion of the program do you think helped?" She says, "Well, I didn't do anything you recommended. I just decided it was time to get well." So that was
Exactly.
a nice,
Oh,
humiliating experience, and I think good for the soul.
yeah. But, you know, in part it was some of your doing. You know, it's that interaction that made them realize, and that, you know, that commitment to actually just come see someone, and that in their head was enough.
Oh, yeah, the
Yeah.
therapeutic visit is
Yeah.
therapeutic. I mean, the
Yeah.
visit can be therapeutic, as you say, but, when we start thinking about the nutrition is the only thing you can do, obviously, maximizing the placebo effect. The placebo just means to please. It doesn't mean
Mm.
you're giving them a fake thing.
Mhm.
One patient came back, and I gave her a therapy, and she came back and she was better. And she said, "Doctor, I appreciated the knowledge you put forth to give me this therapy, but what I appreciated most was that you cared about me."
Mm.
And it's like, wow. And I did care about my patients, and I wanted them to get it better, partly because I cared about them, and partly because from an intellectual perspective, I wanted to know if my therapies actually worked. And I
Mhm.
was always, yeah, if it worked. So, I
Yeah.
mean, people, it was kind of like a cheerleader in a way. And
Mhm.
that does have therapeutic value. It does not
Yeah.
diminish the benefit of the diets and the nutrients and things like that. But, good practitioners will utilize both.
Yeah, absolutely. And I love your perspective on this. And I don't hear it often and with the people that I speak to. And I really appreciate the way you view that, because we are the cheerleaders, and we also cheerleaders for ourselves, because we are trying to collate information, you know. And I always tell my patients that, you know, tell me every little tiny thing that has worked, not worked, how you're feeling. Little signs and symptoms of the body tell me so much about what is going on for you, and it's all for my clinical data over the years. I'm gaining in my own textbooks in my head,
Sure.
not written them like you did, or have. So into nutritional dietary therapy. So how do you feel? Is there a specific way you tell patients to eat? And or is it very individualized and personalized to everyone that you see? So let's dive into that, and where we can really
Okay.
access the power of nutritional medicine through diet.
Well, it's both. It is general, and it's also specific. The general recommendation that applies to almost everybody is you've got to cut down on the refined sugar, the added
Mhm.
sugars. And in some cases, based on their story, you have to cut it out completely.
Mm.
Some people tolerate moderate amounts. Other people, they have what we've called hypoglycemia. It's kind of a misnomer.
Mhm.
We should call it maybe sugar intolerance, blood sugar irregularities, endocrine irregularities due to consumption of sugar. So
Mhm.
if we were to ban sugar in the world,
Mm.
after people survive their withdrawal symptoms, which can actually be quite severe in some cases,
Yeah.
health would improve in many ways. And, just talking to people, everybody knows somebody who feels really bad when they eat too much sugar.
Yeah.
And it's not just obesity, but it's psychological problems, it's achiness, it's fatigue, and things like that. The problem with telling people to cut out sugar is it's easier said than done, because sugar is very clearly an addictive substance. There's a couple different mechanisms. Number one is you get wide swings in blood sugar. The blood
Mm.
sugar goes up really fast because it's a rapidly absorbed carbohydrate. You get an insulin overreaction, and then the blood sugar drops too far. So you get a cortisol, a norepinephrine or epinephrine reaction, and then it shoots back up. And so it's kind of like bouncing up and down like a big sine wave. And so people become addicted because when the level's too low, they know somewhere in their brain that if they eat sugar, they're going to feel better for at least a short period of time. So you got to
Mm.
deal with that. And then there's probably an opioid mechanism too. They did a study in rats where they gave them either the standard rat food with drinking water, or
Mhm.
the same diet with drinking water that contained 10% sucrose.
Mhm.
And the ones that got the sucrose, when they gave them naloxone, which is an opioid antagonist, they went through both behavioral and biochemical changes that looked like opioid withdrawal. So
Mm.
there is something that interacts with refined sugar in the opioid system, and that's partly why there's an addiction there. So with all that said, when I say you need to cut out sugar and you look at their reaction, some people say, okay, I'll do it. And that's fine. Other people say, oh, I'm addicted to sugar, or they don't necessarily know it, but I know it. And I say, okay,
Mm.
it is an addictive substance. If you've ever been addicted to anything, you know that you're going to suffer for a few days. And so just stay with it. Call me up if you need any support. We got a few ways of dealing with it. Eat more protein, eat small, frequent meals throughout the day. Take B vitamins, vitamin C, and maybe chromium, which helps stabilize the blood sugar.
Mm-hmm.
And I always say, call me anytime, day or night, if you have a problem. Nobody's ever called me in the middle of the night, because once they know you're there for them, they don't want to bother you. It's the ones that don't like you that call you in the middle of the night. So anyway, they go through this withdrawal because they know it's going to happen. And I tell them, you're probably going to feel much better around the corner after the withdrawal is gone. And that's usually the case. So that's the sugar thing. And then there's all the chemicals. I don't know how many chemicals are in the food in Australia, but in the US, it's horrifying. It's less so in European countries.
Yeah.
And there's so many chemicals in the food that it's almost impossible to figure out which ones might be causing problems, and maybe none, maybe multiple ones. But so what I tell people to do is buy from the edges of the supermarket, not the packaged foods that have a long list of chemicals in them. And many, many people say they feel much better. And when they eat the processed additive-based foods, they feel worse. We never necessarily know which portions of it is. But so no sugar, try to avoid the refined processed foods with the additives. And then we get into the food allergy. About, in my practice, probably 50% of the people who came in had an unrecognized or hidden food allergy, excuse me, that was responsible for one or more of their symptoms. Now, that was a biased sample because the word was out there that Gaby did nutritional medicine. And so we got people who thought they had a nutritional problem. So it's probably somewhat less than 50% of the general population, but it's a lot. Yeah. So based on their history, you look at family history of conditions that might be allergic. You look at personal history of conditions that might be due to food allergy, asthma, eczema, migraines, irritable bowel syndrome, rheumatoid arthritis, other kinds of arthritis, fatigue. And then I always ask them, do you feel better or worse after meals, or the same? And if they say, I feel worse after eating, that's often a clue that they're allergic. If they feel better after eating, it's often a blood sugar problem, not 100%, but a good place to start. So based on what they tell me, I often recommend an elimination diet, 3 weeks, all food. It's listed in the appendix of my book, but in the short form, it's no wheat, dairy, corn, eggs, citrus, coffee, tea, alcohol, and sugar, and additives. And so that's pretty hard to do. We had a staff member who would spend anywhere from a half hour to more than an hour teaching people how to do that. Because if you don't do it right, it's not going to work. And there are people who wouldn't do it anyway.
Yeah.
But most of the people that I recommended this to did it. And probably 75 or 80% of those who did it noticed a beneficial change. So that's where I go. So the sugar, then you're talking about caffeine and alcohol. There's many observational studies show that moderate alcohol drinking is associated with reduced risk of heart disease. But as you know, observational studies don't prove causation. So is it really true that alcohol prevents heart disease? I'm skeptical. It does raise HDL levels, so maybe there's a surrogate marker. But one of the things that I've postulated, and I wrote about this in the chapter on heart disease, is that many people who don't drink alcohol don't drink it because it makes them sick. And what is it about their biochemistry? There is a fairly high proportion of a polymorphism of a enzyme called aldehyde dehydrogenase. Aldehyde dehydrogenase breaks down acetaldehyde, which is ethanol, which is alcohol, goes to acetaldehyde, and that's what causes a lot of the side effects, the hangovers and the risks. Acetaldehyde is broken down to non-toxic materials by aldehyde dehydrogenase. And there are a fairly high minority of people that have an allele which makes them inefficient at breaking down acetaldehyde. And so they don't drink. Now, what is the deficiency of this enzyme also going to do? They're not going to be able to break down other aldehydes. There are endogenous aldehydes produced in the brain and in the periphery. There's formaldehyde in the environment. So I've postulated that the failure to be able to detoxify aldehydes might be the cause of more heart disease rather than the fact that these people don't drink or that they do drink. So anyway, that's speculative, but the bottom line clinically is if somebody says I drink because it helps me prevent heart disease, and then they're lying about how much they're drinking anyway, I have to be skeptical about that. And then others say, should I start drinking to prevent heart disease? And I usually say no.
Yeah.
And then caffeine, the other one is caffeine. There's observational studies that show that coffee drinking prevents a number of different diseases. Other studies suggest that it might increase the risk. It may not be the caffeine. There are other compounds in coffee, such as chlorogenic acid, which might be beneficial. So it's kind of an open question, and I take it individually. But certainly the caffeine is a problem for specific groups, those with chronic anxiety, those with insomnia, those with cardiac arrhythmias, and some others. Those with fibrocystic breast disease, often they get all the caffeine out of their diet and they do much better. Many people are unaware of the fact that the half-life of caffeine can be very long. They did a study in people with insomnia, and their half-life was as much as 11 hours for caffeine. They'd ingest caffeine, and 11 hours later, they'd still have half of it in their system. So if people say, I only drink coffee in the morning, but I can't sleep, that has not proven to me that caffeine is safe for them. So I always tell people with insomnia, try 2 weeks with no caffeine and see if it makes a difference. Sometimes it does, sometimes it doesn't, but it's worth a look.
Yeah, I've noticed that too. Incredible. I want to say a few points that I want to mention is that, back to chemicals in our foods. So we don't really have the data, do we, on the combination? And we have them singularly, and we have safety ranges, but we don't have the combination. And same in context to multivitamins and pushing all of these different compounds, micronutrients together in multivitamins. We also don't really have the data on that, do we?
Well, we've got some, but not
Yeah.
nearly as much as we'd like. For example, we know that zinc interferes with copper absorption. And then people say, well, should I take a multi that's got both of them? And I say, yeah, because you will get some of the copper in. But if somebody's got a zinc multivitamin that's got zinc but no copper, long-term use of that can be a problem. And then what else do we need to know? I mean, they say that iron and vitamin E interact, that iron destroys vitamin E. So what are you going to do about that? One of the things I do is I often recommend iron-free supplements because a lot of people don't need iron. You can do lab tests. This is one area where I always test baseline for iron status. And if they're in good shape and they're not having, for example, excessive menstrual bleeding, I won't give them an iron supplement. But if they do need an iron supplement, you're looking at things that interfere with iron absorption, such as calcium, other minerals. Vitamin E might be destroyed by iron. So I have them take the iron separately as an individual pill in those situations. Other than that, it's a lot of guesswork, and it's possible we're doing some things wrong without knowing it.
Yeah, I know. It is. And it is much like that with pharmaceuticals in some instances, or sometimes all instances when we're multi-prescribing. So yeah.
And the side effects of the pharmaceuticals that interact can be much worse. I mean, if you have a drug that causes the level of another drug to go up, you can end up with liver toxicity, kidney toxicity, many different problems. And there was a drug that was used for GI problems that they took it off the market, not because it was toxic in itself, but because it interacted with other drugs and made the other drugs dangerous. And despite sending letters to all the doctors in the country, and despite putting a black box warning, physicians were still prescribing it in combination with contraindicated drugs. So they took it off the market because it was dangerous because of the way doctors were prescribing it, not because it was dangerous. So you got to know about interactions. And nutrients
Absolutely.
interact with drugs. They interact to some extent with each other, but mainly I have a large chapter at the end of my book on the clinically relevant drug-nutrient interactions.
Mm-hmm. Yeah, and that's one thing I really like about the naturopathic education is that we go into detail because obviously we are doing so much, phytoceutical medicine, and so herbs, nutrient interactions. We are learning about that in detail, and because it is serious, and we need to know those interactions, and they are medicine, so we have to take it seriously, and so it's a very important thing to understand. Yeah.
Yeah, in my experience, I know a lot of naturopaths. I taught at Bastyr University, which was one of the naturopathic schools in the United States. I
Oh, did
taught there
well.
for 9 years. It's where I met
Wow.
my wife. She's a naturopath.
Mm.
And I was very impressed with the depth of knowledge that they have. It's not the same education. I mean, they wouldn't be able to do hospital care with prescription drugs and all that stuff, but that's not what naturopaths want to do anyway.
No.
But in terms of what they're trained to do, most of them do a very good job. And when I get calls from former patients who want to know who to see in their area, I usually recommend a naturopath.
Mm-hmm. Mm-hmm. Yeah. No, I agree. We have a slightly different perspective of it in Australia to America, but yeah, we are becoming the most growing industry for clients and patients to come to versus traditional medical care because they are not finding the answers or the healing that they want to. And so it's driven by them, which is great. And so we are just trying to be the best that we can be and know as much as we can because it's always continually changing. And this is what my next question will be to you is there's always these new exciting, or for me, it's also about how the nutrients are absorbed, so the digestive, the microbiome, the small intestinal, the ability for it actually to pass through into areas of the body and actually be absorbed in different ways to measure that. It obviously is available. But there are so many different things coming out, as we've talked about with folate. There's sort of like the new fads that are coming through, but not sort of giving too much value to the fads. But what are the things that you're excited about that you want to research next, or things that you've heard about? What's sparking your interest in the field at the moment?
Yeah, well, niacinamide, vitamin B3,
Mm.
it's always been one of my favorite nutrients. I learned when I first started in this field that there was a book written in 1949 that showed that it's very effective as a treatment for osteoarthritis. And that has always been my primary therapy. I think it works as well as or better than glucosamine sulfate. It also causes many side effects, which are very positive: more energy, better mood, better sleep, things like that. It has to be done carefully because excessive doses can cause liver toxicity. So we do monitor liver enzymes, but when we keep it at a safe level, I've never seen hepatotoxicity. But so niacinamide back then was one of my favorites. And in recent years, there was a study published in the New England Journal of Medicine that it helps prevent skin cancer, non-melanoma skin cancer. So basal cell carcinoma and squamous cell carcinoma, which are huge problems.
Yeah.
And it reduces them about 25%, which is a statistically significant benefit. And it was published in the New England Journal, which is a conventional, highly respected journal. And because of that, many, but not all of the dermatologists are actually recommending niacinamide to many of their patients. What is less well known, but very intriguing, is some evidence that it might be useful for preventing and treating glaucoma. And that's
Yeah.
new information that's coming out. There's an animal model, genetic strain that gets glaucoma automatically when they get older, and they gave them high dose niacinamide and it prevented it. It appears to work by stimulating defective mitochondria in the eye, in the retinal ganglion cells. And they've done preliminary work in humans, and it does appear to be effective as far as improving visual fields or improving various surrogate markers of glaucoma. And that's still in its early stages, but that would be a dramatic benefit if it pans out, if it turns out to be effective. As far as the newest stuff, like I said, there's a lot of stuff. The main problem in nutritional medicine is not the newest stuff that's exciting. It's the old stuff that nobody's using.
Yeah, resurgence of, yeah.
Yeah. So my goal is to make people aware of many of the things that have been studied over the years that are effective and safe and are not being used. One of the things that I helped promote a lot was the so-called Myers cocktail, which is an intravenous combination of nutrients, magnesium, calcium, B vitamins, and vitamin C. And I actually took over the care of Dr. Myers' patients in Baltimore, Maryland, when he died. And they
Wow.
all had these amazing stories of how this IV therapy was so dramatically effective for them. But nobody knew what he was giving them. None of the charts said it. He had never written about it. So I kind of had to figure it out, and I changed it some. And I still called it the Myers cocktail because he was the guy that gave me the idea. But
Yeah.
based on that, if you want to read about this, I wrote an article that's available in PubMed. Just Google, just go in the search engine, Gaby AR, and scroll down. It's called Intravenous Nutrients, the Myers cocktail. Talks about how to give it and what it's good for. But you can knock out asthma attacks in 2 minutes. You can knock out migraines in 2 minutes. I saw one guy who was a morphine addict, and he was withdrawing, and he was pacing around and sweating and anxious and crazy. And I hooked him up to this IV. I had to walk up and down the hall with him with a butterfly needle on his arm because he couldn't sit still. But literally within 5 minutes, he was completely normal, at least appearing so. And it lasted 36 hours. We did it again. And it knocked out the withdrawal symptoms within minutes. So there's other things you can knock out. Viral illnesses, fibromyalgia, chronic fatigue syndrome seems to respond. But it's not something that's new. It's just something that that I used a lot in my practice and have tried to get doctors interested in.
Yeah, I see it coming back a lot, and I recommend it myself to many patients and having their IV of the Myers, and tried it many times myself. And a nice dose of magnesium in the veins is a very nice feeling.
Well, that's what they say. We won't get into that. Well, never mind.
Something for off the podcast.
Yeah.
So yes, all right, brilliant. I'm also excited about. I love niacin, and the flushing component I've used in sauna therapy and things like that as well. It's not a nice feeling. It can feel quite dramatic in the skin, but yeah, I see generally in most of my patients, when I'm even doing the testing in multiple ways, that we are so deficient in B vitamins, B6 particularly. I also see B3, B2, B12 as well. It's quite a demand, I think, on the body. We have a lot of usage for all of these things.
Absolutely.
Yeah.
So regarding niacin, I don't use niacin a lot because of the flush, because it's so uncomfortable. I mean, if you're doing detox, as you mentioned, according to Ron Hubbard, that's the way to do it. But niacinamide does not cause the skin flush.
No.
And it's also not as taxing on the liver. So there's reasons to use one and reasons to use the other. But if you want to lower cholesterol, you have to use niacin. Niacinamide won't work. But for most other indications, for the skin cancer, for glaucoma, for osteoarthritis, things like that, I always have used niacinamide.
And what were the dosages? Do you know in the studies what they were aiming towards for the dosages of the niacinamide?
Well, there was a randomized trial where they gave 500 milligrams 6 times a day, and it was definitely beneficial for osteoarthritis. There's a citation in my book. It's in a journal. I believe it's called Inflammation. That's the name of the journal. And the liver enzymes did go up, but not outside the normal range. But because of the risk of hepatotoxicity, which is extremely low, Abram Hoffer, who treated schizophrenia, said 1 out of 2,000 people who take 3 grams a day of niacin or niacinamide will get chemical hepatitis. So that's 1 out of 2,000, but it's still chemical hepatitis. So because of that, I've always limited myself to 500 milligrams 4 times a day instead of 6 times a day, or 1,000 3 times a day. That's I don't want to risk the adverse effect, even though it's rare. And it does seem to work at the lower doses in my experience with patients. So 500 4 times a day. For the skin cancer prevention, what they're using is 500 milligrams twice a day. That's probably reasonable for glaucoma. But again, if you're prescribing this, if you're any more than 1,500 milligrams a day, or if you're dealing with somebody who's at risk of liver damage, like an alcoholic or somebody who's got chronic hepatitis, you want to err on the side of caution and definitely keep a check on the liver enzymes by blood tests.
Mm. Yeah, there's so many things. I lecture often on cannabis and endocannabinoid system, which was what I'm doing in America at the moment. And it's liver enzymes are always one to watch for many things, isn't it? That we're doing, even herbs that we use, all the phytoceuticals, because it's the liver is the important part that's processing everything, isn't it?
You only got one of them.
Exactly. It is lucky it regenerates though, so we are lucky about that one.
That's true.
It's such a pleasure talking to you, Dr. Gaby, and such a commonality between beliefs. And I love talking to people like yourself and just hearing about the wonderful work that you're doing in the world. So at the end of the podcast, we always ask sort of 3 rapid fire questions. Okay. So I've got one in relation to you and your specialty. The next one would be your top trick to live smarter, not harder. And the other one will be your top tool or trick or supplement for health. And so it's just a rapid fire. So I'll let you think about those. But for you, as a starter, what is your, so if you could fix one global deficiency, what would it be?
Okay, well, I'm not sure you're talking about nutrition, but I think one of the major deficiencies, at least in my country, is attitude.
Yeah.
I think we need to improve. People hate each other in this country because of politics.
I know.
And, people are not willing to do the work necessary to be healthy or to be successful. It's not everybody, but it's too many people. So I think we need to be grateful that we're here on Earth, and we need to consider that we have a body that's been given to us, and we're obligated to take care of it. And in countries where medical care is free because of national health care, in the United States, it's largely that way. We've got Medicare, we've got Medicaid, we've got health insurance. I think people should view being healthy as a charitable donation, because then you're not spending tons of money being in the hospital where it could be spent in other more beneficial ways. So I've always thought, have a good attitude and do whatever you can to keep yourself healthy.
Yeah, I like that. That's a different spin I didn't expect. Great.
Okay,
That's
well,
so very good.
Go.
So the next question is a top trick to live smarter, not harder. What would you say?
Live smarter, not harder. Well, it goes to attitude too. But for me, for example, I know that if I eat after 8 p.m., I gain weight and I feel terrible. So what do? I eat after 8 p.m. And I keep telling I got to stop eating after 8 p.m. And then I went like 6 months not eating after 8 p.m. and I lost 20 pounds and I felt great. So find ways to do what you need, what you know you need to do.
Yeah, you generally know what to do, don't you? We just don't do them.
I know what I need to do, and I don't always do it. So that goes back to the attitude, and be grateful that you've got what you've got, and do what you can to keep it.
Yeah, I love that as well. That's brilliant. And so the next one, you can either choose the trick or the supplement, but top tool, trick, supplement for health.
Okay, well, as I said earlier, if everybody, you don't want to give it to people with end-stage renal failure and people on certain medications, but if most other people increase their magnesium intake, there would be dramatic improvements in health. And actually, I was so sold on magnesium that I wrote this little book. It was really a pamphlet book. It was just called Magnesium. And it was written many years ago, and I reviewed the literature. And the way I started it off is hardly ever a patient leaves my office without the recommendation to increase their magnesium intake.
Yeah, I love that. All right, so where everyone can find you. So you have your amazing book, which is Nutritional Medicine, and they can find that on your website. So Dr. DOCTOR Gaby, GABY.com.
drgaby.com, right?
Anywhere else that people need to know.
There's sample chapters up there. It's an expensive book. And shipping to Australia is frightfully expensive. There is an ebook version, an electronic version, which does not have a shipping charge. But there are sample chapters on the website, drgaby.com. And you can see if it resonates with you and you think if it's right for you, because it is an investment. But the purpose of it is to teach practitioners how to practice expert nutritional medicine, do it safely and effectively.
Yeah. And I think we need to, as you said, know how to discern the evidence and really look at that properly and then make our own judgments around that. And we need good literature like you've written to be able to do that. And we can't always have the time if we're seeing patients actively and hours after hours to do the incredible research that you've done. And this is why we pay and the investment for the resources.
Well,
Yeah.
thank you.
Yeah. So, Dr. Gaby, it's a pleasure. Thank you again. Wonderful conversation. And I look forward to hearing more about your adventures and your research as the years come by.
Okay, thank you, and enjoy Colorado.
Thank you.